Afternoon, everybody. Welcome to this webinar organised by the East of England Cancer Alliance, and it's about our introduction to our virtual group consultation cancer care review project. My name is Peter Holloway. For those who don't know me, I'm a GP, and I have the honour of chairing the primary care group of the East of England Cancer Alliance, whence this piece of work originated. A couple of housekeeping items. We would prefer if the presenters could give their presentations, and we'll have more than enough time for questions after the presentations. And just to let you know, this meeting is being recorded and will be available on our website, and we'll send the link out afterwards. I'd just like to spend a short time describing how we came to this piece of work, and it brings together really two strands. One, it was previous work that we've done in the primary care group on cancer care reviews, and also the changes in consultations forced upon us by the coronavirus epidemic, particularly in primary care, as we moved to remote consultation. This is ongoing, and the consequences and dilemmas around continuing remote consultation will be a subject for a webinar in itself, but I promise you that is a topic that we're addressing separately. But this really builds on previous work that we'd done in the primary care group. We became acutely aware 4 or 5 years ago that cancer care reviews for the majority of primary care, and I say the majority, not everybody, to some extent have become a tick box exercise. So at that point, we undertook a project to try and make cancer care reviews more meaningful, and we considered things like what we thought were the minimum standards for a cancer care review and what it actually ought to be about. And we used the Macmillan template for that, which we continue to use to this day. One of the legacies of that pilot was the training that we'd instituted across the region for nurses in primary care to provide ongoing support for cancer patients in the region. But one of the things that came out of that project was that it was still hugely challenging to get GPs and primary care to engage meaningfully in the cancer care review process. So it made us begin to think about alternative ways that perhaps we could do that. And even though cancer care reviews are an important part of our quality outcomes framework that we use in primary care, I think there's still considerable work that we could do to improve them, most importantly for patients, but also for primary care. The changes in consultation that happened over a year ago now, as a result of the coronavirus pandemic, primary care, as most of you will know, was mandated by NHS England to change the way it worked, and we went over almost overnight to a so-called total triage model. Part of that was an increasing use of consultations remotely, particularly by video. And we became, and leading on from that work, we did some work about video consultations at the time, and it became clear that there was great opportunity to use video consultation and remote consultation in a group context, perhaps to use it in cancer care reviews. So we set up a project group under the auspices of the Cancer Alliance, and we were very fortunate to get funding and approval from the both North and South Alliance boards to continue the project, which brings us to where we are today. We have involved patients in this process right from the outset. I'd like to think, and unless they tell me differently, that they've been active participants in the group, and a presentation from our patient representatives is what we're going to kick off with. Then Liz Towers, who's a Macmillan GP in Essex, is going to talk about cancer care reviews in more detail. And finally, we see this as an opportunity to bridge the primary and secondary care interface as far as patients are concerned, bringing the clinical nurse specialists into the group consultation process, and Charlotte Etheridge, who's a urology nurse specialist at ESNEFT, is going to talk later on in the presentation for that. And then at the end, we will have an ample opportunity for questions and answers. So at this point, I'm going to hand over to Fiona Carey and Lee Belcher, who can introduce themselves, and they're going to talk about the patient perspective.
Fiona, you're on mute.
That was a good start, wasn't it? I'm terribly sorry. Hi, my name is Fiona Carey, and I've been a renal cancer patient for 20 years. I've had lots of METs. I've been treated with surgery, radiofrequency ablation, radiotherapy, and maybe about to embark on some immunotherapy and TKI combined therapy. I retired about 9 years ago from my job as Assistant Director of Comms at the OU, and got involved kind of by accident as a patient rep with the NHS. I've never had a cancer care review, as far as I know. Somebody might have ticked a box after a discussion somewhere, but I've never knowingly had one. And that might be because I fell through the net. It might be because my status as being discharged was ambiguous. It might be because they hadn't been invented. I'm not sure. But I think a cancer care review has got to be a good idea. And I think that the timing, or broadly 6 months or so after diagnosis, seems about the right time. I think for most patients, this represents a point where you've probably stopped reeling and panicking. You're probably through your first phase of treatment, at least. You've probably recovered from the more grueling effects and immediate effects of treatment. So it seems like a good time, really. You're also possibly feeling a little bit cast off into the wilderness if you've been discharged from secondary care, and maybe facing all sorts of questions that are beginning to surface to which you don't know the answers. So it's a good opportunity, I think, to take stock and try and get your life back on track. So I think the principal thing about it is that it's a perfect opportunity to ask lots of questions. You might, for instance, have questions about your treatment and diagnosis. You might need to ask about long-term effects that you're just starting to realise are, might stay with you quite a long time. You might want to clarify your prognosis. You might have discomfort at treatment sites. You might be dealing with an outcome of treatment, like, you might be involved in stoma care, you might have diabetes, any number of things that you realise are going to be sticking around for quite a long time. But there are lots of other issues as well, apart from the sort of strictly medical ones. And Sally, can you pop the next slide up? No, don't do it yet. Don't do it yet. Hold on. A few years ago, I was asked if I'd give a talk to Macmillan GPs about the less expected, less predictable consequences of having cancer. And I said, yeah, I think I can think of a couple. I'll put my hat on, and think about, and I was a bit hard pressed, really. And then I started to make a mind map of the consequences of cancer in my life. And you can pop that up now, Sally. I'm not going to make you go through it. I'm not going to talk through it. But it was astonishing, the areas of your life that were impacted by this thing that's happened to you. I mean, from psychology, financial, work, domestic arrangements, your health generally. For me, I ended up with a disability I hadn't really expected. The effects on your family and the ripples, with work colleagues. Just the aftermath of convalescence and so on. Emotional energy, huge amount of emotional energy and headspace being taken up, as well as a few silver linings, actually, which for me have mostly been wheelchair basketball, a bit unexpected. So I'm not proposing to go through that. You'll be very relieved. If anybody thinks it's useful, you're very welcome to use it. But the point is, by this time, there's a lot of other stuff emerging from the woodwork about related to your cancer that you probably need some help with or answers to. So things like money, going back to work, can you do it? Do you need help? How do you do that? Things like dealing with your appetite, but things like relationships, you know, there might be effects on your sex life. How has your partner reacted to this? And how do you have those difficult conversations with partners, with friends, with relatives? How have your children dealt with your illness, for instance? All sorts of issues like that. And the really big one, you know, the really big issue about anxiety, the really big scar, regardless of where you had your cancer, the really big scar is the one in your head. And the business of worrying about every little health event, you know, even an aching knuckle will get checked out. There's always this suspicion that given your history, you know, something else might occur. And, you know, is it going to come back? So, you know, you need to find ways of, if you want to find ways of having these discussions, finding some answers, it's got to be a good idea to have a cancer care review and say, look, this is where I am. How do I go forward from here? How do I get my life back? So I think it's a great idea. The weird thing about this situation is that I'm personally not entirely sold on the groupness of it, haven't been all along. I'm just not sure about doing this in a room full of people personally. I'm not shy, I'm not embarrassed about my cancer, I'll talk to anybody about it. But I think I'm a bit of a selfish, self-centered piece of work. And I don't know if I want to sit and listen to everybody else's problems and issues when I think my own plate is full. You know, I don't know if I've got time for it. So I know there are benefits to this, and Lee is going to talk you through them and to talk about the benefits of the groupness and the benefits of the virtualness as well. So with my skeptical hat on, I'm going to hand you over to Lee, who's going to persuade you. Thanks.
Thank you, Fiona. Yeah, so Fiona and I came together and had a discussion, because I'm a patient also, and talked about how we felt about this virtual online format for the cancer care reviews. And as Fiona has mentioned, she's somewhat skeptical, whereas I was straight away buying into the strengths of that. So after our discussion, I went away and just thought about a few key points about what are the benefits of the group setting, and then what are the benefits of that being online. And one of the things I've now encountered a number of patients, and one of the things that patients often report is that they feel lost and alone in the system during their treatment. Although there are lots of medical professionals around them, you don't tend to have continued relationships or the opportunities to discuss your daily concerns. And so a group setting, I believe, will actually allow patients to share their experiences with others who are in a similar situation, so can empathise with what their peers are going through. And it's important to be able to ask questions not only of the professionals, but from other people who are going through what you are going through, are potentially further ahead in that process, may have come up with some solutions or workarounds that could be really beneficial for you. You can benefit from the experience of other patients. You can also benefit because in a group setting, you may feel unconfident or concerned to raise an issue that you find difficult to talk about, but you often find in the group settings that somebody else is prepared to actually raise that issue then. So it's still discussed, and you have the opportunity to benefit from the knowledge that's shared around that issue. And conversely, you may be in a position to offer some insights to the other participants in the group, to share from your experiences, to think about the ways that you've dealt with things, the workarounds that you've come up with. And patients really do enjoy helping other patients and knowing that they've provided some support and empathy for them. You may also find that people raise issues that you've even forgotten about. You think, a couple of months ago, that actually was an issue for me. So there will be information in that forum that would be useful for you to hear. And another thing, sadly, that patients often say is that they either feel overwhelmed or intimidated in consultations to ask questions directly of a medical professional. Much easier to raise those questions in a peer-to-peer setting. And the group setting, it really reduces the obligation on the individual to feel the need to speak. They may just be happy to absorb the information that other people are sharing and are still benefiting from that, or they may then start to feel more confident to get involved and contribute themselves. But what most patients really want is empathetic support, emotional support, mental well-being as they're going through their treatment. And the group setting really offers multiple opportunities for people of a similar situation to offer empathy, support and caring to each other. And you can get that from practitioners, from the other patients as well. So the group setting really allows patients to access a range of information that wouldn't necessarily have been available to them otherwise. And whilst patients will have very differing needs coming into those forums, there is still an effective peer support. Now, in terms of those settings being online, what that provides is a social gathering opportunity. Participants can be safe in their own home, particularly if they are still immunosuppressed, if they're going through treatment, but they still get to benefit from being a member of a group. And they may find patients decide to stay in touch with other participants online, maybe even all of the participants. They may carry on and develop a support group for each other. The online setting also means that other people can join in the sessions, so the patient can be supported by family, friends, carers, anybody that needs to be alongside them to help them not only during the session but after what might be quite an emotional time. And the online setting is really valuable because when people are going through treatment, they look for every opportunity to not actually have to go into a clinical setting. You really tire of that. So any opportunity to not step your foot through the doors of the hospital, the doors of the surgery are really, really valuable. And I think that in this day and age with the COVID changes that we've all had to adapt to, many people are used to online meetings and are familiar with the technology that's required to participate in those. So I'm absolutely sold on the group consultation format and the fact that it's online. Have I managed to convince you, Fiona? You're just on mute.
I know. I definitely give it a go.
So, shall we hear a little bit more about the actual process itself from Liz Towers?
Thank you so much, Fiona and Lee. So I'm Liz Towers, I'm at Macmillan GP for Mid-Essex. If we can go to the next slide, Sally. I thought probably it was just important to share with you the changing story of cancer. More of us are getting cancer. And in actual fact, the statistics tell us that 1 in 2 of us will get cancer in our lifetime. And while that sounds alarming, and you might say, well, why is that? Really, it's because we're all living longer. And the majority of people who have cancer are in 65 and over. And if you actually look at this first slide, 1990, we had about 1.2 million people living with cancer. By 2015, we had 2.5 million people living with cancer, and they estimate there's going to be over 5 million people living with cancer by 2040. But if you can see, most of these patients with cancer are age 65 and over. So although that's perhaps an alarming statistic I gave you of 1 in 2 of us getting cancer, it's because we're all living longer. If you look at the bottom green line, it's talking about survival. And in 1970, if you were diagnosed with cancer, you could expect to live a year. That was your average survival. That's pretty shocking, really, isn't it? By 1990, so 20 years on, average survival was only 2 years. 2015, average survival's gone up to 10 years. And they're estimating now by 2040, average survival will be 10 years or more. So actually from 1970, cancer was mostly about dying. And that's why a lot of people still have this big fear of getting cancer, because it's, you know, that thing that you're going to die from. People sometimes even, you know, worry about saying that word. They can't bring themselves to say, do you think it's cancer, doctor? They talk about the big C. But now actually increasingly cancer is about living with your illness, living with, being cured from it, and living beyond it. And that's because of the vast improvement in outcomes with ever sophisticated treatments. But while that is a good story, not everybody is living well with their cancers. So if we go to the next slide, Sally. So yeah, living beyond cancer doesn't mean necessarily you're living well. So at least 1 in 4 of those living with cancer face poor health or disability after treatment. I think Fiona has mentioned that already. Over 70% need emotional support. Again, what Fiona was saying about, you know, it in your head, that anxiety, the depression, these are statistics from Macmillan. And 1 in 5 people living with and beyond cancer have unmet needs. So what are these unmet needs? Next slide, please, Sally. So yes, so not everyone is living well. So Fiona again mentioned about some of the consequences of treatment. So that could be anything from fatigue, heart problems, you may develop diabetes, you may be at risk of thinning bones, osteoporosis, you may have peripheral neuropathy where you get pins and needles in your hands and feet. And 1 in 4 will have to deal with those consequences. And at the same time, over 70% of cancer patients have 1 or more long-term condition. So they're dealing with other illnesses as well, not just their cancers. And there's that fear of recurrence. And again, I think both Fiona and Lee mentioned that worry. I've got a pain. Does that mean my cancer has come back? And the statistic for breast cancer patients, 1 in 5 breast cancer patients face a recurrence, but also fear that. And when we talk about some unmet needs, there are things which probably we don't think about. And Fiona's mind map, I think, was very explanatory in a way. There are other things that we probably, certainly as health professionals, don't think about. So people with cancer are 37% more likely to be unemployed. More than 1 in 5, 22% of people with cancer suffer with loneliness in this day and age. And then there are practical and personal needs as well. So 32% of people feel they have got no support or very little support in practical and personal needs. And that big thing of emotional needs. So 45% feel that they haven't had their emotional needs addressed. Next slide, please, Sally. So I think because we have realised that people are now living with their cancers, living with them, dying with their cancers, not necessarily from them, that there was a real push for what we call personalised care in cancer. And Macmillan were key to helping develop something called the recovery package, and I'll touch on that in a minute. But personalised care in its simplest form comes down to 4 key areas. So we talk about treatment summaries, and years ago we used to ask for end of treatment summaries. So somebody who's gone through their cancer treatment, we would in primary care receive an end of treatment summary. But now it's more about management summaries, because people don't just have often 1 treatment, they often have multiple treatments that may go on and off for years. But within those summaries, there should be things about treatment intent, the diagnosis, the outlook, potential adverse effects, how to spot recurrences, and a rapid re-entry to the specialist. And that's really important for us in the community in primary care to support people. Health and wellbeing events have been around for a little while. Interestingly, the majority of them, I may be wrong, but certainly in our area, are still being delivered in the hospital. But these health and wellbeing events are really important because they give patients an opportunity to meet other people, other patients, but also to have access to physios, occupational therapists, dietitians, clinical nurse specialists, and actually talk about their shared experiences. As part of cancer treatment now, patients are given what we call a holistic needs assessment, and this touches on everything: their physical well-being, psychological, social, spiritual, but it's very much a person-centered care approach. Gone are the days when one size fits all. Everybody is an individual. They will have their individual needs in their social setting. And then the fourth part of personalised care is the cancer care review, which is what we're really talking about today. But if you look at that recovery package circle and that wheel going around the outside, it's about supporting self-management. Most patients want to get on and live their life, but they can't do that unless they have access to the right information and support. Next slide, please, Sally. So cancer and primary care. Cancer has always been a speciality, if you like, that sat in secondary care, and that primary care have had very little to do with it. But I think, you know, the slides earlier show that now cancer is a long-term condition for many people. And actually, most people, even while they're going through their active treatment, the majority of their living is in the community. An average practice, 8,000 patients, will have about 280 patients living with and beyond cancer, and it's set to double, like one of my earlier slides showed. And of course, a lot of those will be diagnosed 5 years ago or more. We do know, and the evidence shows, that people after the first year of being diagnosed with a cancer attend more frequently than other patients of the same age to their GP, but also to A&E. And I think that really reflects some of their unmet needs. They get a pain, they don't know where to go. They feel anxious, they don't know where to go. And often they bounce around with those unmet needs because we're not actually geared up to support them. And as I've already said, 1 in 4 will experience consequences of their cancer or treatment that affect their quality of life. So I think primary care now is key, and we need to step up to the mark, really, because we are going to be the people to support patients because of this improved survival. Next slide, please, Sally. So what's a cancer care review? Well, at its simplest, it's the conversation between a patient, their GP or practice nurse, and it's about them having the opportunity to talk about their cancer experience and concerns, understand what support is available in the community, and receive that information they need to begin supported self-management. Next slide, please. Next, that's lovely. So what does QOF say? We're all geared up to QOF. So QOF used to be just that you'd have a cancer care review, and as Pete said earlier, often that was just a tick box. You know, people could just, GP could ring up a patient and say, how are you? And they'd say, well, I'm okay, thank you, doctor. And then you tick your box, and that was the cancer care review done. Now QOF is actually told that 3 months after diagnosis, primary care are required to reach out to the patient. And I think that is key, that actually we make contact with the patient, and it can be something: how are you doing? We're here. Is there anything you need? But at that time also to suggest to them that there is something called a cancer care review that can be delivered in primary care. And we are talking in this virtual group cancer care review of doing that 6 months after diagnosis. Now, I know QOF will say 12 months, but for this, the virtual cancer care review, we're talking about 6 months. Next slide, please. And I mentioned about holistic needs assessment. So this will have already been done with the patient and their clinical nurse specialist. I'm just showing you, this is one of the Macmillan HNA templates. And it should be offered to a patient prior to them coming in for the cancer care review. They can bring their original one with them, but I think, as Fiona said, often you're at a different place and there may be other issues that you're actually dealing with. And it's a sort of prompt giving patients the opportunity to think, what's important to me now? They might not want to talk about all of those things in those little boxes. There may be one pressing concern, and it could be continence, for example. But that then allows the GP or practice nurse who's ever going to deliver that cancer care review the opportunity to make sure that they are primed to be able to help that patient. Now, originally, of course, cancer care reviews were done on an individual basis. The idea of a group and virtual group cancer care review is that we will be sending these questionnaires out to patients who've all had a similar tumour site, whether that, and we're going to be starting with gynecological cancers and urology cancers. And often you will find that there are certain themes that come through it. And certainly for both gynae and urology patients, if they've had pelvic radiotherapy, continence issues can be a large issue for them. So this template, which we will be sending out to patients, gives not only the patient the chance to think about what's important to them, but also the GP or nurse who's going to deliver the review, an opportunity to say, well, it sounds as though these things are important. Next slide, please. And this is really just what the Macmillan template looks like on System 1. And I would really say that this is not a tick box. The worst thing a cancer care review can be is sitting down in front of somebody who is just firing questions at you. This is about the patient-centered care, patients telling us what they want to talk about. But the template gives us, I suppose, a framework. Next slide, please. And I think Lee very eloquently said about the benefits that she saw of virtual group cancer care reviews. So it is personalised. It does give patient choice. So they don't have to have it as a group. They can still have it as a single consultation. It definitely gives flexibility. I think we've all benefited from the fact that we can do these online meetings. And certainly if you're not feeling up to dragging into a GP surgery, how much better to be able to do it from your own home. I think the sharing and learning from your peers, so actually sharing experiences. And as Fiona said, you know, it may be that you've dealt with an issue a few months ago or a few weeks ago, but now it isn't such an issue, so you can share that experience with your group. And of course, onward support and signposting. There is a multitude of support agencies out there, but a lot of people don't know of them. The real importance for patients to start picking up their lives, being signposted to, whether it's benefit advice, exercise classes, stop smoking. You know, we know that exercise reduces your risk of recurrence. And I think, again, the beauty of these virtual group cancer care reviews is if we see that a lot of patients in that group want to talk about, I keep saying about their continence, we could bring in a clinical nurse specialist to support these virtual group cancer care reviews. And that's really where Pete mentioned earlier. It is so crucial now that primary and secondary care link up, that we support patients. They don't belong to either primary or secondary care. They belong to themselves, and we're there to support them. And I think part of this group that I've been lucky enough to be part of is that we have been working closely with our secondary care colleagues. And on that, I will introduce you to Charlotte, who's a Macmillan Urology CNS at ESNEFT. And I've now realised that ESNEFT stands for East Suffolk North Essex Foundation Trust. I hope that's right. Over to you, Charlotte.
Lovely, thank you ever so much, Liz. That's absolutely right, and I'm based at Ipswich as part of the ESNEF team. So I've been asked to give a bit of a wider picture about personalised care with regards to the primary and secondary care interface. Next slide, please. So I think we need to acknowledge what we mean by these different terms. So primary care in this country is the first point of contact for patients and their families. Patients and families can access directly. And we just need to remember that primary care involves lots of different types of professionals. General practice is the first group that tends to be thought about, but also we've got the community pharmacists, dentists, opticians, etc. So what do we mean by secondary care? The only type of direct access that patients and their family have is through A&E, so an emergency route. Other than that, all care is planned in terms of a referral from primary care, whether that be a GP or an advanced nurse practitioner, etc. And that tends to be for conditions, and I'm urology, so benign condition might be waterworks problems, and a malignant condition might be a raised PSA for prostate cancer. But those are direct referrals from GP to secondary care. We have to acknowledge as well that patients have more than one condition a lot of the time, and we can even have patients on more than one cancer pathway. So for urology, we often get patients on other pathways such as colorectal, etc. These are disease-specific referrals, so unlike primary care, particularly with general practice, there's an umbrella around the patient. It's for everything. In secondary care, you would refer for a disease-specific reason. Traditionally, this care is provided in the hospital setting, but more recently, people are doing outreach clinics, including chemotherapy, follow-up clinics and GP practices, using GP practices for ultrasound, but also we're learning about remote monitoring through the COVID pandemic. It's important to mention tertiary care because a lot of our patients do have care, and centres that we access from ESNEF might be Southend or Basildon, Addenbrooke's or Norwich, and it's important that we all communicate between the different care sectors because at the end of the day, the patient is the patient, and we need to work around them. Next slide, please. So what do patients tell us about the interface, so the link up between all these different care providers? So some of the feedback from the National Cancer Patient Experience Survey from 2019, and this relates to ESNEF, so some Suffolk and Essex patients. Some patients describe feeling left in the dark and a bit stuck, as Fiona and Lee sort of pointed out earlier. But on the positive side of things, a lot of patients were thanking professionals for their help, particularly around sort of kindness and time and care. So at ESNEF, the national average for us being considered to work well together, so that's primary, secondary and tertiary care, the national average is 73%, and that's what we achieved as ESNEF and the primary care groups associated with that trust. So that's fantastic as a starter, but that means that 1 in 4 patients and families didn't feel that we worked well together. So it's about understanding a bit more about that. Macmillan are obviously fantastic in terms of the work they do to support patients and help with guidance, and NHS England have also recognised that cancer is often a long-term condition and we need to have similar pathways for patients and support throughout, much like we might do for COPD. Macmillan also suggests we look at cancer as a jigsaw, which I think is a really useful pictorial way of us all realising that without each other, we can't deliver what our patients need. So I've mentioned the different types of care provider, but we haven't mentioned social care, mental health services and end-of-life care, because all of those teams also need to be involved for a variety of patients. I think one thing to point out is that we also need to be a little bit better, and I include myself in that, in really acknowledging the vulnerable and the excluded groups, because they are at greater risk of their needs not being met. And Liz has alluded to that, and Macmillan have done a lot of work. And when we mean excluded groups, we're talking about ethnicity, we're talking about sexual orientation, we're talking about migrant status, which is a bit more topical these days, and things like disability and age. So what are the common issues that we all face, patients and us as healthcare providers? IT systems are the bane of our life. Fortunately, at Ipswich, certainly we've got our electronic notes up and running. In the community, System 1 or a typical type of system is up and running, and there's a little bit more engagement between systems, but there is a long way to go. So we do heavily rely on us as professionals communicating with each other. As the team have alluded to before, the key times that patients and research has shown, they fall through the gap when they leave hospital and when they transition between services. So we need to be really clear, if we're changing medication, who's next to do that? How long is that for? Who's responsible? And patients want to know who, why, what, when and how. And that's what we'd expect if we were the patient. Next slide, please. So had a bit of a look at the literature in terms of what do we mean by an interface and what do we think is best practice. Initially, I'd written across settings, but actually on reflection, we need to be good within our own setting. So there's no point me wanting great communication with Peter or Liz as GPs. I actually need to be a good communicator and have good relationships within my own team. So you can read for yourselves things around communication, collaboration. Liz has always and Pete have touched on innovation, and certainly with COVID, there's a massive opportunity for us to deliver care closer to patients' homes and tailor it to patients. So one of the positive things that came out of a very difficult time. In terms of benefits and outcomes, there are outcomes for patients, particularly around experience and safety. But also, I think as professionals on this webinar, it's about understanding that we get that enhanced sense of job satisfaction, and that hopefully enables us to stay and also to engage and provide better care with our patients. Next slide, please. Thank you. So the whole webinar is around personalised care, and the focus is on the virtual cancer care reviews. But as Liz discussed in terms of the Macmillan agenda, in secondary care, we do holistic needs assessments, we do care plans, and I'm very grateful to Liz for discussing management summaries rather than treatment summaries, because actually, particularly in urology, we have a lot of patients who live with their cancer and may not have treatment for one reason or another. So personalised care has a number of different facets, but where does the interface come into play? So really it's around this relationship, it's about this joining up interface. We have to see this as a new relationship with patients, staff within, and the system that is the NHS. And it's about our patients being allowed to be active and empowered in the way their care is planned and delivered. And that's certainly the nuance of all the guidance that's coming out. However, we've got to actually make this work, and it's not about ticking boxes, as my colleagues have already said. I think the difference with personalised care from how we've traditionally provided care, and I've been a CNS for 20 years now, is that it's about tailoring it to the patient. We often tailor care with regards to what the system can do and the resources we have, but it's about saying, what does that person need? So I might have two patients, each with a renal mass, and we would either treat them or follow them up quite differently, and their support needs might be very different for the same condition. So it's about saying, well, what matters to them? And that's where the holistic needs assessments, the cancer care reviews come in. So the key areas in terms of the interface are promoting self-management, as many different pathways are doing, particularly in prostate cancer, as Pete will be aware, being one of the leads. Wellbeing is a huge thing, and we do a lot at the hospital, but I think it's around putting it on as a community rather than just as different providers. Digital infrastructure is key, and I mentioned IT and electronic notes, but it's having a way of accessing information across the system, and also about recognising that it's not just about hospital or GP practice support, the community itself can be empowered to provide support. So when we come to the interface, if we truly have that collaboration and that relationship and that partnership with our patients and between ourselves, that is a way of us contributing to them, hopefully patients having not only high quality care, but it's about timely care and about being accessible to all patients. Next slide, please. So whistle stop tour, but it's about just bringing it back to the fact that I've been asked to talk about the interface. I've discussed what do we mean by, and I've talked a bit about primary, secondary and tertiary care in terms of the differences to patients, but actually for the patient, we should be one healthcare system, they are one patient. The patient voice has come through quite starkly today. I've had an absolutely fantastic description of true life and what things matter to patients. And it's about understanding the good things that we're doing, but also what we can do to improve and to work collaboratively with our patients. Talked a bit about some of the things that the best practice interface might look like, collaboration, innovation, communication, and also a bit about where that fits in with personalised care. Fundamentally, though, we're all here for the patient, and actually that should mean the patient, the family and the community. I hope that you feel that that's given you some information on what we feel to be the interface. Thank you so much. I'm going to hand over to Peter now, because Peter, you're doing a wrap up and Q&A, I believe.
Thank you very much, Charlotte. Indeed, thank you all for what I hope you'll all agree were actually three absolutely terrific presentations. So thank you for that. There's some questions posted in the chat already, but otherwise raise your hands. But I think what I think has come through all these presentations is the fact that we are beginning to see cancer is not the death sentence it was 30 years ago. People are surviving for a lot longer, and certainly in primary care circles we talk about treating cancer now as a long-term condition in the same way that we would describe diabetes or chronic lung or heart disease, and using those principles of continuing care for the benefit of patients. And as presenters have highlighted, the patient is central to this. This is not a tick box exercise. This is not about QoF. It's trying to make sure that we design services to support patients in the best way that we can. I think it might be helpful if we can describe the pilot itself. We've talked a lot about why we think it's worthwhile, and I'd like to stress right at the beginning, this is optional for patients. It's not going to be compulsory. Fiona said that it's something that she may not necessarily wish to do, and group work isn't for everybody. But we believe that there are benefits in terms of shared experience and mutual support that patients can participating if they so wish. What we're proposing to do of the pilot, we're going to run sessions in 2 ICSs, mine in Suffolk and North East Essex, using PCNs as the basic population management structure. In SNE, we're using East Suffolk PCN, which is a large PCN of about 150,000 patients. In Mid Essex, where Liz works, I think 3 PCNs are working collaboratively. The pilot will provide training for nurses to participate in the sessions. We going to concentrate on urology and gynecology, because we don't really know in terms of volume. So we thought if we're working in a group setting, we thought it was really important that we chose groups of patients, obviously with common shared experience. And the project is we're working with Anglia Ruskin University to do a formal evaluation of our project. So that's the project in a nutshell. We hope to kick off pretty soon. So open up to questions. So if you've got any questions for either of the presenters or myself, raise your hand or post it in the chat even. There was a question from Stuti earlier on about whether this is going to replace the formal cancer care review that we have to do for QOF. I don't know whether you've got any views on that, Liz.
I think we have to see how this pans out. I don't think it's for us to say, but I think, you know, when it's evaluated, and just to say we have actually, again, looking at how important it is to get patient voice. Although you're absolutely right, Pete, we had ARU doing the evaluation. We have actually been very fortunate that Lee has almost rewritten the script now. And with her expertise, is actually going to be doing this evaluation. I don't know whether you want to mention anything there, Lee.
Yeah, we felt that this was actually a great opportunity for co-production. So we took the toolkit that the university had presented to us, and it went to the Patient Advisory Board and the Cancer Champions Committee, and the patients ripped it apart, basically. And so we decided, well, let's start with the patients as the starting point. What would they actually like from a CCR, and what would they like to be asked about that CCR process? And so we've stripped the evaluation survey for the patients right back, and accordingly we've stripped back the staff survey as well, and we've brought the 2 in alignment. So there is actually, we are asking the staff, have they fulfilled and met the needs that the patients have specified? So I'm really excited that the patients have actually been the starting point for this evaluation survey, and should continue to stay very central to that.
Thanks, Lee. So Stuti, I guess the answer to your question is, as I posted in the chat, we can't see any reason why we shouldn't use this mode of doing cancer care reviews to fulfil the requirements of QOF for practices. But that's one of the things that we hope to find out as the pilot progresses. I can see some hands going up, so I'll get to those in a minute, but I'll just answer the other question in the chat from Susan Barry. We have developed specific patient information leaflets and a lot of communication for patients around this project, and I'm sure that we can circulate those with the slides if people are interested. All right, so we've got a couple of hands up. One from Trish Marriage. So when you're answering a question, if you just say briefly who you are and the organisation that you represent.
Hello, I'm Trish. I work at Sutherland Lodge for Virgin Care, and I've been involved previously on cancer care reviews at previous CCGs. I've not done them yet through this one. Fantastic presentation. Well done, all of you. How are we going to plan like the logistics of how this is going to be delivered to our patients, or is that on our upcoming meetings, Lisa, that we're going to be having?
Hi everyone, I'm Lisa Motley. I'm the Programme Manager for this project with the East England Cancer Alliances. We will be rolling it out with individual PCNs or groups of PCNs, and that will involve a gap analysis approach, which will go through the toolkit, adapt it to make it bespoke, and look at where there might be some gaps in training, etc. And it's going to be different according to the PCN's position.
Okay, thank you.
Thank you, Trish. Thank you, Lisa. Stuti obviously looks as though she wants to come back in on the cancer, the QOF issue. Stuti.
Hi, thank you. It's just trying to work out. Thank you, first of all, for this wonderful presentation. And it's very interesting to hear the views of Fiona and Lee, and to hear from Liz how it would work. But I'm just, using this as an opportunity to have a sort of face-to-face chat about it, because I had actually contacted Macmillan about group consultations, and what I understand is that the QOF bit is very personalized and it's aimed at the needs of the individual. And what I would like to get a better understanding about is how in a group, how we fill in the template, which is meant to be very personalized as part of cancer review. And from a cancer point of view, people will be reluctant to discuss their personal issues. So it doesn't fit into the requirements of all our cancer patients. So it may fit in the requirements over and above of the QOF review. And it's an excellent plan linking with PCNs, delivering it through involvement of secondary care, through cancer specialties, and having group consultations. So I can see it from that perspective, but what I fail to understand is how it would offer a personalized care and fill in the requirements of QOF. And I go back to QOF because this is where we need to get our GP colleagues and PCNs buying into it. So I'm keen to know how that would work.
Fiona, your hand went up when Stuti was speaking. Was this a separate question, or was that for to answer Stuti?
It's partly to do with what Stuti was talking about. There are two things I'd like to mention, if that's all right. So there was a slide of I think it's the Macmillan electronic template for a cancer care review, and it struck me that if I was whether one-to-one or if it's used in a group situation, I'm not sure. But if I was in a one-to-one with somebody, does that mean that they're kind of sitting sideways, reading from the template, reading the questions, and then filling answers in as I'm talking? Because that doesn't sound very patient-centered to me. I would feel as though somebody had to do this and that they weren't genuinely interested in me. It was just a thing. It would look like they were, ticking boxes, really. So that's just the thing. That's how it feels to be a patient. The other thing I just wanted to touch on is slightly tangential, but it's about the language we use when we talk about patients not living well after treatment or cancer. According to have a disability of some sort, most patients have a measure of anxiety. And I just want to say that, anxiety doesn't necessarily mean depression. And the business of having, the effects of treatment. So personally, I've got a rebuilt upper GI tract because of my renal cancer and a Whipple's. I've got diabetes because of that same surgery, and also significant mobility issues, again, because of the extent of the surgery. So I don't think that defines me as not living well. I think I'm living really, really well. I'm having a ball, and my life is no tragedy. So I just think we need to be a bit careful about what living well or not living well means, because I'm living with all those consequences, but I'm doing all right, really. so far.
No,
It's about language.
No, thank you very much for sharing that, Fiona. And I think that's something, as I think the points that Stuti has raised actually do show the differing perspectives from professionals and patients, and that we've still got a long way to go to bridge those, despite our best efforts. I return to Stuti's original point. I mean, I think, as I said, I think it's one of the things that really want to find out from this project is, can we satisfy the requirements of a template-based approach, even if it's a Macmillan template-based approach, by doing this? Is you know, Fiona's made the point that she'd actually be quite horrified, rightfully, I think, if she thought someone was just reading from a template. And again, that returns to the tick box approach that we're really trying to get away from. I think I do understand, though, that to get primary care engagement, we do have to make sure that we satisfy the requirements of QOF, or at least some aspect of the PCN cancer DES. I mean, that's one of the key, as I said right at the beginning, that's one of the key parts of learning from our first pilot, how difficult it was to actually get primary care and GPs engaged in doing meaningful cancer care reviews. You know, even if we greased their palms with silver, that didn't necessarily do the trick, which normally would do the trick with GPs. So, you know, it was big hurdles. So by using this approach, by trying to get the cancer care reviews facilitated by the practice nurses with specialist training, and people like Charlotte contributing from a secondary care point of view, I would hope that we would be able to demonstrate a case actually is what we're doing is actually a lot more meaningful and better for patients than even the Macmillan template-based approach. Trish wanted to come back in again.
Hello, hi. I just wanted to draw, I think, Stuti's comment. I think it will be like the gold standard, really, and it will be an addition to the QOF, and it will be a great thing when you undertake your cancer care reviews to springboard into the PCN support that we're hoping to offer, and it gives those people also a chance, like the speaker said earlier, when they're overwhelmed or intimidated, to ask on a personal level, so questions which are quite embarrassing. So I think it can be incredibly useful, and it's about tailoring your care individualized for each patient, and bringing Fiona then into that answer is, when we undertake a cancer care review, well, I'm speaking from myself perspective, I don't have my computer on, I don't use a template, I have a chat with my patient and try and engage with them, understand how they're feeling, is there any way I can help them, whether it's physical, psychological, mental, and then to try and offer them, signpost them to appropriate services that, you know, if I can't offer any help in any way. And part of the questions, one of the big questions you ask is, what would you like to discuss today? Not like I've got my agenda, I know what I want to talk to you about, but what do you as a patient, what is troubling you most today? Might not be anything that's on this tick box exercise, so to speak, that people always assume, but it's very important to ask that of yourself, Fiona. You know, what have you come for today? What would you like to discuss? How can I help you? Rather than just using a tick box as an approach. I hope that helps.
Yeah, thank you for that, Trish. And I think you've summed up good general practice in a nutshell. Is actually addressing the patient's agenda, not the professional's agenda. And perhaps that's a suitable note on which to conclude. We're just past time. So thank you for everyone for attending. Particular thanks to the speakers for 3 excellent presentations, which we will be circulating afterwards with the link. And I'd like to finish by giving a big thank you to Lisa Motley, who's the transformation lead for the Alliances, whose drive, passion and initiative we would have never got this pilot off the ground. So thank you very much, Lisa and presenters, and good afternoon to everyone.
Thank you.